Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners, and welcome back to another episode. Today, we're diving into an essential topic for every anesthesia provider, local anesthetic systemic toxicity, or LAST. I'm so excited to be joined by Dr. Richard Wilson, DNAP, CRNA, FAANA. Dr. Wilson earned his master's degree from the University of South Carolina and his DNAP from the Medical University of South Carolina. He is currently the Assistant Program Director, East Coast, with Ursuline College's Somnia Nurse Anesthesia Program, and he continues to practice clinically and mentor CRNAs through the CRNA School Prep Academy. He also authored the Blood Component Therapy chapter in the latest nurse anesthesia textbook and was named a Fellow of the AANA in 2023. With his clinical experience and academic experience, Dr. Wilson is the perfect guest to help us understand how to recognize, treat, and prevent LAST. So let's get into it. Hello, my favorite learners, and welcome to another episode of our podcast here, talking about pharmacology today here with Dr. Richard Wilson, DNAP, CRNA. Thank you for being here, Richard, with me today. I appreciate your time. I like to have everybody, all of the guests, come on and kind of speak to your journey in education to tell our learners a little bit more about being in academics as an anesthesia provider. So tell us about your story.
Yeah, thanks, Chloe. Thanks for having me, and thank you for what you're doing in the community with providing this podcast. I know this is going to be hugely beneficial to a lot of the learners, especially our newer generation, as we look at kind of the ways they like to learn. So I really do appreciate you stepping out and stepping up and doing this. And really, when you look at my journey into academia, it was kind of, I guess you could say, not the normal per se, because really, I never truly thought I was going to be in academics. I went into nurse anesthesia to obviously practice as a nurse anesthetist. And then within about a year from my graduation, I had spoken with my program director at the time about potentially, going to a facility, being a clinical coordinator, wanting to work continuously with students and educate. She had kind of had some sessions with simulation that we as seniors got involved with and educated and helped with. And then, kind of quickly moving through it is, then I became a clinical coordinator at the facility we were at. And about 3 years into my journey as a nurse anesthetist, our facility was looking at expanding. And in expansion, they wanted to actually open a new campus. So we were affiliated already with a program with providing clinical training for them, but now they wanted to open a second campus for them. And I interviewed for it. Surprisingly, I got the position. I really did not think I was going to get it at the time. I told my wife, don't worry, I'm just going to interview for practice, and then got offered the position. So then I really had to make a decision. And it's, 15 years later, I'm still in it and loving it.
That's awesome. I actually have a similar story. So I also didn't think I would ever go into nurse anesthesia academics, that's why I love asking this as an open-ended question at the beginning of these podcasts, because I feel like a lot of students don't see themselves in this world, and seeing how it kind of evolves and the mentors that it takes to get us here is amazing. I was the same clinical coordinator, and my mentors were like, you should probably apply. And you're like, I don't even care if I get this. And then you don't get it, and you're like, oh, I'm actually really disappointed. Maybe this is something that I want to do. That was my stories. Yeah. Now, here we are doing academics, and I'm glad that you're in this space with me. So I appreciate you.
Thanks.
We're going to start talking about, I did a podcast solely on local anesthetics. So we won't dive into like the local anesthetics and how they work, but today we're talking about local anesthetics with local anesthetic systemic toxicity, which is a mouthful. So we refer to it as LAST. So let's start talking about the signs and symptoms and how it kind of progresses from the CNS into a cardiovascular collapse kind of progression. So can you talk a little bit about that?
Absolutely. And LAST is one of those things that you really hope you never see within your career, but you want to make sure that you're prepared for, right? It's things like, anaphylaxis, malignant hyperthermia, all of these things that you hope that you never see. But you do need to be ultimately prepared to treat it when it does occur. And treatment always starts with recognition. So when we look at recognition part of this, we've got to see what are the signs and symptoms. And we know that when you look at the literature and you look at the studies that we see these CNS signs before we're going to see the cardiovascular signs. Now, what does that mean? That means that we get a little bit of a chance, well, we can talk about that a little bit later in this episode, of treating it before it gets into full-blown cardiac arrest. But we've got to be able to recognize those signs and symptoms. But unfortunately, some of those central nervous system signs and symptoms are very minute. When you start talking about agitation, tinnitus, ringing in the ears, right? You talk about the circulorum numbness, those kind of things. You're like, that's a little bit maybe a drug reaction, nothing major, anything like that. And then it starts progressing, right? So you get those early and then you get those late stages. And when it starts to get those late stages, we start to see those really, really severe central nervous system signs. That's when we start getting into the comatose states, those central nervous depression states, eventually leading into maybe even seizure activity before we get into the comatose state. And it progresses pretty quickly through there, right? So as we start to see that concentration of local anesthetic within the vascular system increase, we start to see that progression of those central nervous system signs that then eventually we're going to see the cardiac arrest or the cardiovascular signs and symptoms.
I love how you said that these are things that you hope you never see, because again, with crisis management, you truly hope. I always compare, I think all of us talk about how it's like driving a car, right? Like anesthetics are driving a car, and sometimes there's a deer in the middle of the road, and those are the things that we need to manage at that point. And I love how you talked about how minute those symptoms can be, because I mean, in OB, I do a fair amount of OB in my practice. And, I always tell students when I'm teaching them about the test dose, the epidural test dose, and telling patients what symptoms to look for, because then they start to go, wait, maybe it is metallic in my mouth, and maybe I am feeling ringing in my ears, because it's almost that psychosomatic thing of making the patient start to think that they're feeling it. So I usually say like, oh, if anything's strange or different, and then I kind of go into the ringing in the ears, like you're sucking on a penny, a metallic taste in your mouth, because they are so minute, like you said. So I do appreciate you mentioning that, because it's so true.
Well, and then when we also talk about those CNS signs, and you were doing OB, which you have your patient obviously not sedated, you're not using Versed at this point in time or any kind of benzodiazepine or anxiolytic, right? But I don't do OB. A lot of what I do is in the orthopedic trauma side or some of the neuro side and in some general, but the point for me is when we go to stick a catheter in somebody's neck or a needle in somebody's neck to put a interscalene block in, right? Or we go into the groin to do a femoral block, we are obviously sedating them. And so what we're doing is we're actually giving them an anxiolytic, a benzodiazepine, which is going to confuse some people with these symptoms. Because one of the symptoms is confusion. Well, once we give somebody benzodiazepines, you've been there, we've all been there, they start to talk out of their head. They start to say things that sound confusing. The other part of that, and we'll get into this because I'm sure we want to talk about the cardiovascular symptoms, is it raises that seizure threshold. Now, that's a good thing. That's a good thing for the fact of the central nervous system signs. But usually we recognize the central nervous system signs, we can start treating it in hopes to avoid cardiovascular collapse. However, now what this does is when we're using that benzodiazepine and we're delaying that seizure that we're going to see, if we get to high enough concentrations, we're actually bringing that cardiovascular collapse, the recognition of those late stages of the CNS symptoms, right, closer to when cardiovascular collapse is going to occur. So we have to actually be even more cognizant of what's going on and more aware and watching this overall.
No, that sedative definitely plays a role. It almost puts a mask over everything that's going on. So we have to be even more vigilant into those little minute details. So I love that you mentioned that, because I think our learners can definitely benefit from both of our experiences in the different areas of anesthesia, because they are very different in terms of how much we have to be tuned in with what we've even given our patients. So that's great. I love that point. So let's kind of talk about the why. What happens with this? We're kind of going into anatomy and physiology level at this point. So can you kind of explain the mechanism of LAST and which patients are at the highest risk for?
Absolutely. So you've got to look at kind of your at-risk patients, right? And when you're really looking at your at-risk patients, it's those that are going to be either your extremes, right? You've got your extremes in your ages, so your pediatric and your geriatric populations. And even when you look at the way that metabolism of the body is, in eliminating local anesthetics is those that have those renal and those hepatic diseases and insufficiencies that can lead to it. So those are some of the patient populations. We also have to look at the fact of, yes, in OB you have it, right? But we also look at the fact that when we start talking about doing peripheral nerve blocks, it's huge because we're giving large volumes of a local anesthetic. I mean, when you're doing a local anesthetic, you're injecting a local anesthetic for a femoral nerve block or an interscaleral nerve block, you are sometimes injecting 30 and 40 cc's of bupivacaine in these individuals. So, the more we inject into a space, the higher risk that we're actually going to raise we're raising that chance of them to have LAST that could occur overall. And really what it's doing is what is the purpose of local anesthetics? It blocks conduction. When we look at it and it's going down the axon and we start talking about that propagation of the nerve impulse down the axon, what we're now looking at is the fact that the local anesthetic is going to block the sodium channel. Therefore, what is going to happen? It's going to block propagation of that nerve down that axon to then stop whatever we're wanting to stop at this point in time. Now, hopefully it's the axon of the nerve in itself that is a sensory or motor nerve, right? So we're hoping that on the peripheral side, that's what we're doing when we talk about giving it as a peripheral nerve block. However, when it gets into the vascular side, it doesn't say, hey, by the way, I'm in the vascular system. I have no clue, I have no business being here. I should not be blocking these sodium channels of the heart or the conduction system of the heart, right? It doesn't recognize it. It just says there's a sodium channel. Here's where I'm supposed to be. And so then we see it start to get into the conduction issues there, right? That's why we see these arrhythmias that occur first before we get into cardiovascular collapse, because now it's getting into the conduction pathway. And so that action potential that takes place, right? When we start looking at that action potential that takes place with the cardiac system and the conduction system, we're now affecting it. And that's where we get the arrhythmias.
That just painted a perfect picture of how it works. It's not where it's supposed to be in that dose and volume. And so that's when it goes to those different sodium channels. I love you summarized that perfectly, in my opinion. So we're going to talk now about the anecdote that we need to have ready. So this is, again, worst case scenario. This is a bad day, hope it never happens type of day. So what type of things we talk about, we have a LAST cart. I mean, honestly, everywhere should if you're doing these types of cases and anesthetics. So let's talk about lipid emulsion therapy, lipid rescue, whichever you want to say. Can you kind of talk about the pharmacology as to why this works for LAST?
Absolutely. I love this aspect of it because we really need to think about the history of all of this, right? And really, when you look at the history of all of this, and I love looking back over time to figure out how things came about, because the only treatment for this was really a hope and a prayer that something was going to work out, or basically that a lot of patients passed away, died from local anesthetic systemic toxicity. And the only hope at that point in time, before they developed lipid rescue protocols, was for a patient to get on cardiopulmonary bypass long enough for all of this to metabolize and get outside of the system, and then hope they come back off cardiopulmonary bypass at that point, right? That used to be the only way to do this. And then they really started researching this, and they were like, oh, you know what? Again, please don't call PETA on me. This was not me. But they started looking at it, right? And they started going, hey, I think if we take these animals, take these rats, these dogs, right? They were testing on rats and dogs. And they say, hey, if we got a massive dose of local anesthetic we're going to give them and put them in a systemic toxicity state. And then we think if we give them lipids, this is actually going to make it worse. This is going to make their symptoms worse. This is actually going to push them over the edge. And what they found out is it actually fixed everything. It actually treated the toxicity, and the patients, or these animals at the time, right, did not go into all of these cardiac collapses that we've been talking about. So they started now utilizing. Now, here's the aspect of it. And what we have to understand is these are retrospective studies when we start talking about LAST in human populations. They're all retrospective studies. And we know, right, if you've studied research in itself, you know that retrospective is correlation, prospective is causation. So we're really just seeing in these cases, if this was used, what was the correlation to it, right? Because nobody's going to volunteer, and I'm sure no IRB is going to actually approve it and say, please give me a whopping dose of bupivacaine until my heart is about to stop, and then give me this drug, and let's just see if this works overall. I'm sure IRBs would go crazy over that. So these are all retrospective studies, and that's why you'll see sometimes in the lipid rescue protocols, you may see a little bit of a difference in how some people treat it. But the one thing everybody's agreed on is that 20% lipid emulsion is effective. And it's because it creates a lipid sink. So what it's doing is it basically takes that local anesthetic molecule. When you look at the fact that the local anesthetic molecules have hydrophilic ends, right? And we start talking about all of their structure. Basically what it does is it absorbs that local anesthetic. So instead of that local anesthetic being free in the vascular system to bind to the sodium channels in the vascular system and the cardiac system, it is now, when you look at it, it's now within that lipid. So now it has the ability to then be eliminated from the body in that manner versus now being free within the system to bind to any sodium channel that exists.
Yeah, that is so true about looking retrospectively. And I guess I've never really thought about that aspect of even all crisis management in general. A lot of it is retrospective because who's going to sign themselves up for any type of crisis scenario? Definitely not me. And the IRBs would go crazy, as you said. But that was a great summary of how it works and the history of it. I love a good history lesson. So I think our learners will love that as well. And it's important because that's how we do the future, right? Is by learning by the past. So I love that. Let's talk about, so we kind of talked about this offline a little bit. There have been some updates on the dosage of this lipid emulsion therapy, that 20%. Can you kind of speak to the new updates? Because I think a lot of people aren't even aware of this new update, as I was not aware of it.
Yeah, so I can't remember exactly when the new updates came about, but two of the sites that really are very, very kind of beneficial and really up to speed on local anesthetic systemic toxicity and the treatments for it are lipidrescue.org and then the ASRA, which is the Society of Regional Anesthesia, right? And those are really big on keeping up to date. And so for your listeners here, if you're going to follow two sites or look for information on LAST, those are two really good sites to go to. And it used to be that we would have this standard kind of treatment, right? There was 1.5 mLs per kg bolus, and then you would give an infusion at 0.25 mLs per kg per minute. So you had all this calculation you would start to do. Well, what they figured out was over the last several years, they've now started changing that. And so basically they got a 70 kg cutoff. So now what we're looking at is if you've got a 70 kg cutoff, that anybody over 70 kgs, you're just going to give 100 ml bolus over 2 or 3 minutes of this 20% lipid emulsion. Anybody under 70 kgs, now we're going to start going back to what we were using before, which is the 1.5 ml per kg bolus. Give that over about 2 to 3 minutes, and then start an infusion of 0.25 mLs per kg per minute, and then seeing how that does. And over a little bit of time, if you are having still cardiovascular collapse from this, then you obviously are going to eventually repeat boluses or increase your dosages of the lipid emulsion at that point in time. So that's been a little bit of a change. It's just looking at that over 70 kg, where we no longer do that by an ml per kg rate anymore. It's just give them 100 mLs over 2 to 3 minutes. And then instead of the infusion at 0.25 that I was talking about that we use with under 70 kgs, you're going to give a 250 ml bolus of this over 15 to 20 minutes. So that's been the biggest differences that we see. And we still got to remember, though, we have to manage the cardiovascular and the neurological symptoms that are going on. So one thing people need, something people need to remember is just because we started lipid emulsion doesn't mean now we just take our hands off and we just say, okay, let's see what this does. Patients still having neurological symptoms, right? If they're still having seizure type activity, we need to give benzodiazepines to treat that seizure activity. If they're having cardiovascular collapse and we're still seeing hypotension, arrhythmias, whatever it may be, we need to be treating those with vasoactive drugs.
And I love how you talked about initially the calculation of it all and that being a main. I mean, when I looked at this, I was like, why did they change this? I always look at the old and the new and look at the differences and see why it is that there was a change. But I do think you're right in that calculation can be hard, especially in a crisis scenario. There's a lot going on. There's a lot of people usually. The clarity of thought in making calculations is really hard to do. And I love that we're doing this update because I had a crisis scenario in malignant hyperthermia. And so dantrolene versus Ryanodex didn't exist when I graduated. And so it's essentially the same, but it's a much smaller quantity. So all of us in the OR were older, quote unquote, CRNAs, but we were thinking about that 60 mLs, right? So we're all like trying to do these calculations and make sure the thing's right. And being on top of the updates is really important because things do change. And in this scenario, it makes it easier for patients over 70 kilograms. And of course, for patients under, we still do that calculation, especially going into pediatrics. And once it gets into much smaller humans, I say, those calculations do make a big difference. But I do love how you touched on that. And you also mentioned something else that I was going to mention. We will go into a little bit of that ACLS, like you said. So we'll go into that later into the podcast, but it is multifactorial. There's a lot going on, the seizures, the cardiovascular collapse, and we'll kind of talk about what those ACLS differences are later.
Well, that's why it's also important, as you mentioned, this multifactorial issues that we're having to take care of, right? That's why it's important also to recognize and alert. You're going to alert your whole room, right? There's been some times where, honestly, I've been in cases where we had vasoplegia that occurred. And if you know anything about vasoplegia as the audience, then this is a severely hypotensive state that we get. It's almost like a vasodilatory shock type state that occurs. And what do we do with that? We just treat it. We tell them to keep going on with the surgery, and then we're okay, right? And hopefully it comes out just fine. And I've done that before, and we've been just fine with it. This is different. This is because it's multifactorial, because there's going to be so many things that has to occur. This is when you're alerting the room, hey, I've got a problem, right? Because here's the thing we have to remember. This does not necessarily occur immediately. You could place the block in the pre-op area, take the patient back to the room, have them under general anesthetic, and then all of a sudden you start to see problems that occur. Now, here's the thing. You're not going to see your neurological problems at this time because you got a breathing tube on and you got general anesthesia on them, right? But what you may see, excuse me, is those cardiovascular signs. And so you start to see those and recognize it as last. We've got to stop everything. Stop surgery, stop prepping, stop whatever, and get all hands on deck. That includes our circulators. That includes our surgical techs, that includes our other anesthesia providers that are around. Call your help in.
And I think that's where differential diagnosis is such an important topic. And maybe we'll do a podcast later and bring a bunch of different providers in because we've had all these different experiences. And it's hard to educate someone, even on a podcast, on what differential diagnosis looks like because it is so multifactorial. But being educated on LAST, being educated on MH, that's why we do these things, so that your differential can get to that conclusion a lot faster. And I always tell students, especially in that MH scenario, algorithms and crisis checklists exist for a reason, and we should be using them in that MH scenario. I was the one that was like, we were kind of all running around. I was like, let's pull out the crisis checklist. And it wasn't because I was the hero of the scenario. It's because it's literally laminated right there. And I'm like, let's just go through and make sure we've done all the things we need. We've called MHOS. We've done all these things. And that's why they exist. So that's my personal experience on using crisis checklists. And you should have these numbers in your head and memorized. However, they are also available in all areas where we provide these anesthetics for a reason, and they're a great resource to use. So I'm a huge proponent for crisis checklists because they come in handy for sure. Now we can kind of dive into how do we prevent this? So for students listening that are learners, or our providers know what we do, but can be reminded of, best practice guidelines. I think all of us need a little bit of a refresher sometimes on what we should be doing in practice. So can you speak a little bit to things that we can do to help prevent LAST?
Absolutely. And when you start talking about preventing LAST, it has to come with first the recognition of it, right? And it comes first with recognizing, hey, my patient's at risk for it. Now, who's at risk for it? Everybody's at risk for it. We all are. It doesn't matter if you're a very healthy individual. If I inject enough ropivacaine, whatever it may be, into your IV, you're going to go into local anesthetic systemic toxicity. So we just know some of them are at higher risk. Like I mentioned, the hepatic dysfunction, the renal dysfunctions, pregnant patients are more at risk. So are our extremes and ages that I mentioned earlier. And how do we prevent that? Well, one, we need to have a checklist. Do we know where our local anesthetic box is? our treatment box is, our last treatment box is, if we have one, and we should have one. There should always be one in the area of where you're doing your blocks. It should not be that, hey, we're going to put one down the hall because it's convenient down the hall, and it needs to be right there where you're going to be placing all of these blocks. Now, the other aspect is, I mean, you got to look at this. If you're doing spinals and epidurals, if you're doing peripheral nerve blocks, there's a little bit of a different technique in obviously placing these. So there's a little different in technique in preventing LAST from occurring. But when you look at the spinals, epidurals, and those kind of things, right, it's really going to be test doses. So you're going to really look and say, okay, hey, I'm going to give you 3 cc's of, bupivacaine with epinephrine. And then you're going to wait for a couple of minutes and see if the patient has a reaction or not. So if all of a sudden, you give this bupivacaine with epinephrine, you give this through a 3 cc test dose to them, right? And the reason that works is because they may have some symptoms that occur, but then again, we are not going to send them into full toxicity at that point in time. That's why it works really well. So if they start to have that ringing in their ears, circle oral numbness, and it doesn't go away, if they start to get severely hypertensive and tachycardic from the epinephrine that is in that local and, mixed in that we just talked about, then you're going to have an assumption that, hey, I must be in the vascular space with this, and therefore I don't need to now continue to give 10 cc of this through the epidural, right? I don't need to hook up the bag through the epidural and run their epidural infusion in, because we're going to get, and that's when you have to again take it out and start all over again. Now, when you start talking about doing peripheral nerve blocks, and let's talk about doing single shots versus doing catheters. And so for single shots, like I mentioned earlier, you're putting 30 and 40 cc's of local anesthetic in at a time. So we all know, let's use ultrasound guided regional anesthesia. That helps a lot, right? Because now we can actually see where our needle is. However, we're getting within millimeters of these nerves in these vessels, and around every around every nerve, guess what we have? We have vessels. And when we look at that aspect of it, we're within millimeters of these things. So if you just turn your head and look at the screen, guess what happens with your hand? You potentially move your hand, and now you may be in the vasculature where you were not originally in the vasculature. So this is why it's important of a technique that I have used honestly and seen since I graduated in 2006 is aspirate, right? When you think you're where you're supposed to be, aspirate to make sure you're not in the vessel, inject 5 cc's, aspirate again, inject 5 cc's, and keep doing that until you have administered that full 30, 40 cc's, whatever it may be. Because again, 5 cc's is going to create some issues, but it's not going to put you in full-blown arrest at this point in time. And so if you're just doing 5 at a time, then that means you're checking to make sure your hand didn't move and push the needle into the vascular space to then give intravascular local anesthetic.
Yeah, I just love your experience in regional anesthesia, because it's such a different mindset than mine in OB, where, we do the epidural, we give the test dose, we inject. It's hard, I would say, for students. I always tell students, I know the patient's having contractions, they're in pain, they're screaming, but we still have to do that 5 mLs at a time, aspirate. It takes a lot longer. You want to give your full dose and get the patient comfortable, but you have to do those safety measures. They're so important. I told you I was going to tell this story offline, but my sister actually had an IV a positive test dose on her epidural catheter when she was delivering my niece. This was years and years ago. But the provider did aspirate negative heme, because one of my favorite questions to ask OB students is like, why do we have the windows in the catheters, in the epidural catheters? And, it's to look for heme, right? So you're looking in these windows for any heme. There's negative heme, and she still got an positive IV test dose on her epidural. So, and her sign was tachycardia. She almost passed out off the bed. She was like, my mom was standing in front of her. She was like, catch me. So that was her sign. So I always think of that anecdotally when I'm providing OB anesthesia, because that epi really will kick in on patient, not everybody, right? We can't do blanket statements, but what's the heart rate with the nurse? We're in constant communication on what the heart rate is and what's going on with the patient. So I think your experience in regional and mine in OB, I think this is great. I think the learners are getting a lot out of this episode, so I appreciate it.
Yeah, and the other thing to remember too, and we can get in a very big hurry, right? When we start looking at production pressure and we start looking, okay, just for an example, I'm going to take Chloe back to fix her elbow. And we're going to now put a interscaling blocking in Chloe to help with this procedure. Chloe's young, she's healthy, production pressure, let's go. Let's just slap this block in her and let's get back there, right? And so one, you could not aspirate because you could be in a hurry and you're like, oh, let's just go ahead and get this done. But the second aspect of that I think sometimes gets overlooked is the monitors, because sometimes we'll say, oh, they're healthy, right? Some individuals may get in a hurry and say they're healthy, let's just go ahead and do this. We don't really need all these monitors on them. And they start with the block. But we've got to get those baselines, and we've got to have that continuous monitoring. So we need to put a pulse ox on them, an EKG, and a blood pressure. And sometimes that may seem overkill, but it's not, because it's helping you recognize the signs and symptoms when they need to be recognized.
I love that you mentioned that, because monitors are super important, and we have to have all those bases covered no matter the production pressure. You're 100% right. So I mentioned it earlier.
But let's kind of talk about the ACLS changes with LAST.
So when we start looking at some of the changes that are occurring, when we start looking at the ACLS protocols, right, and we start looking at how we should manage these patients, the first thing we start thinking about, okay, a patient went in cardiac collapse, we need to go through ACLS protocol. Not necessarily in these patients, because part of the problem here that we're looking at is we're looking at a heart that's failing, and we have to be careful with how much strain we put on that heart. So we're trying to provide a delicate balance here. Because, again, we've got a heart that's going into arrhythmias. We've got a heart that's now going into some failure overall. So we really need to now start looking at what are we going to do when we've got a patient here. Because if we increase afterload too much, we actually send the heart into more failure overall. Because this is not a heart that is failing because over time the pump has gone bad. This is failing because, again, you've got all of that sodium, or you got all that sodium channel blockade going on. And once we get rid of it, the heart should come back up, right? It should come back and be good. But if we have them in a marked state of cardiac depression and we've increased the afterload with some of the things that we use, we actually send their heart into complete failure and really contradict what we're trying to do and what we're trying to treat, right? So, because some of our things would be, hey, let's give epinephrine. Let's give vasopressin. But the other aspect of that is if we give those things in high enough dosages. Now, I'm not saying you don't give epinephrine. I'm not saying you don't give a vasopressin at all. But if you give those in high enough dosages, you actually increase the afterload so much that you put the heart in failure. The other aspect of that is, we mentioned it earlier, and I want to kind of go back to it if you don't mind, Chloe, is how do we treat this? We treat it with lipid emulsion, which then basically encapsulates or engulfs that local anesthetic to be moved through the system to then go through the hepatic, right? Go through the liver to be metabolized, renal to be, excreted. We've got all of that, right? But if we've got something that's got an increased afterload that's making it harder to push the fluid through, to push the blood through, we're actually delaying elimination of that local anesthetic.
No, I love that you wrapped it up again perfectly, where that afterload increase is the reason why we make these adjustments. And it's, again, like you said, not a blanket statement that we never give these things or, every scenario is ever evolving. However, that afterload is so important to be able to get to that point where the local anesthetic is no longer systemically toxic, right? That whole last picture. So this has been just an amazing podcast. I love how your regional experience matched with my OB experience in talking to the lab today. I think that, our learners will remember less epi, no vasopressin. Giving this lipid emulsion therapy is the gold standard treatment, and how it started with the rats and the dogs, and PETA's not going to come after us, but how it kind of changed the practice, the new updates. I mean, we've talked about a lot of things today, but one last thing that I like to guess is to give one piece of advice to an anesthesia learner, whether someone in the throes of anesthesia, just first day starting out. What is one piece of advice you would give to our learners today?
So I actually have two pieces of advice. So I don't follow rules very well, I guess, but I've got two pieces of advice. And one thing is to remember, the days are long, but the weeks are short. And we've said that for years and years. And it's amazing how many of our learners, again, I've been doing this for 15 years, over time will go, you know what, that is so true. That when I was in the thrust of this, when we were going through all of this, it seemed like it was taking forever to get through this. But all of a sudden I look back And I realized I'm only a year from graduation, or I'm only 6 months from graduation, or 6 days from graduation, right? They're like, I can't believe how quickly this actually did go. That's one thing. And then something I always say, and I know this is kind of, I don't know what you want to call it, but anyways, I call this basically the 4 pillars of being successful in anesthesia school, right? This is just something that I've kind of thought about over the years, as especially starting out. Be where you're supposed to be, doing what you're supposed to be doing, how you're supposed to be doing it, and when you're supposed to be doing it. Those are very simple concepts. And if you just do those 4 concepts right there, especially in your early days, so many learning opportunities open up for you in the long run, because the preceptors and your instructors, right, and your faculty say, look, they're doing what they're supposed to be doing, when they're supposed to be doing it, how and why. So we're going to give them more opportunities and look at them standing out. And it's just as simple as that sometimes.
I love that. I had a mentor that used to say, show up prepared with a positive attitude, which kind of gives that, it's a little bit less all-inclusive. I love what you just said. But it reminded me of that. And I always keep that with me and share that with students, because I think it's so important, and every day is an interview. And another thing a CRNA used to say, or one CRNA that I remember when I was a student said, you feel like that S in SRNA will never turn into a C, and then it does. And then you look back and you have 20 years of experience. So I think that is so true as well. The days are long, but the years are short. And that is definitely true. So I appreciate your time, Richard, for being here this morning and sharing all of your knowledge and experience with us. So thank you for your time.
Thank you. Thanks for having me, and best of luck to all the listeners.
Thank you.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.